All right, we are back for video 5. This one is our heavy hitter. And again, we're covering prone positioning and the ARDSnet protocol. So the overview. We're going to be covering a lot in this video. We're going to be covering prone positioning rationale, indications for prone positioning, why we do it, contraindications for prone positioning, why we wouldn't do it, preturn considerations, and the role of the RT during proning, the prone position therapy checklist, rotoprone beds, and the techniques you can use when proning patients, effectiveness of prone positioning, tools for the prevention of skin breakdown, and considerations for prone positioning and demonstration of a prone positioning where you'll get to see me and Autumn laughing. So first, the rationale for proning a patient. There's a couple of different things that one of our textbooks talked about when reasons that you could benefit from proning a patient. The descending pressure effects was the first one. So the transpulmonary pressure differences between your ventral and dorsal alveoli, so your front base compared to your back alveoli, it's reduced in the prone position, and that's actually a good thing. This can decrease the alveolar overdistension, so the ventral lung region, when you're supine, the ventral lung region is going to overdistend and the dorsal lung region is going to not distend enough. So when you're proning them, you're relieving some of the weight that the heart puts on your dorsal lung regions, and you're going to get more even distension instead of one overdistended and one not distended enough. So along with decreasing alveolar overdistension in the ventral lungs, you can decrease alveolar collapse in the dorsal lung, and you can also decrease alveolar shrinkage just all around. The second one is gravity-dependent effects. So the posterior lung mass is heavier and receives more blood flow in the prone position. This results in better distribution of ventilator volumes and pressures throughout the lungs, and it also results in an improved ventilation to perfusion matching and patient oxygenation. And that's just because of the same thing I just said, that there's not as much compression. You're going to get more even distension. You'll therefore get more even distribution of ventilation as well. And then ventilator-associated lung injuries. Results show that proning reduces the amount of lung injuries that we get due to ventilation. It should be implemented early in patients with severe ARDS. If they automatically have that PF below 100, you want to immediately try to prone them. It should also be maintained for 18 to 20 consecutive hours, and then you can flip them back to supine for, I saw somewhere said about 8 hours, and then try it again. So the indications for proning an ARDS patient: failure of low tidal volume ventilation with the patient in supine position. So if we've tried everything and they're still getting low tidal volumes, not life-sustaining, you can try proning them and we might be able to increase that. If their PF ratio is less than 150 millimeters of mercury on ventilation, then we have tried everything. We're doing what we can, and proning is kind of like a last-ditch effort. So then also, if their FiO2 requirements are greater than 60%, proning might be beneficial for them. If they have minimal improvement on a PEEP of 5 or greater, then like we said, the PEEP levels can go much higher than 5. So that would be the greater portion. But if they're just not improving, no matter how much we're raising their PEEP up, and it's starting to get to a point where we don't think that we're going to be doing more good than harm, then maybe we should try proning them. And then also refractory hypoxemia on max vent settings. If they're getting 100% FiO2, if they're on PEEPs of 15, 18, 20, if they're on the tidal volume range that we can put them on and their pressures are all about max they can be, then we've done everything we can and it's not making them any better. So we could try proning. So contraindications for proning an ARDS patient, reasons why we would not under any circumstance do this. If they've got spinal instability or they're at risk of spinal instability, we don't need to be turning them. If they have unstable fractures, they don't need to be turned. If they've got anterior burns, so burns on the front of their body or open wounds on the front of their body, They don't need to be putting a ton of pressure on those and staying that way for 18 hours. If they are in shock, if they're very pregnant, if they've had a recent tracheal surgery, if their ICP is increased, if they're hemodynamically unstable, if they have cardiac pacemakers, or they've had abdominal surgery recently. All reasons we would not want to turn them on their stomach. So then some preterm considerations and the role of us as RTs while we're proning. Preterm considerations. You want to make sure that their neck is mobile enough for you to be turning it and turning them around, because you will have to move their face from side to side to prevent pressure ulcers. And before you do turn them, you want to make sure that you have good documentation of what their head, face, and oral mucosa looked like before you turn them, so that you can track whether or not there's any skin breakdown during the proning process. And then the role of the RT during proning. You're going to pre-oxygenate your patient with 100%. We do this for just about everything. You just want to give them that extra little boost before you start moving them in case anything goes wrong while you're moving them. And then you want to ensure the vent circuit has enough slack in the vent in the right spot. And by that, I mean that you want the vent opposite of the patient's invasive catheters. And you want to make sure that it's in a good spot to where it's not going to get pushed out of the way while you're turning, where the circuit's not going to get wrapped up in anything. That's our only job, is managing the airway and managing the machine that's managing the airway. And then before you turn, you're going to want to suction out their ET tube and their oral cavity, and also check their cuff pressure. You need to know what their cuff pressure was before you turn them, in case you rupture the cuff, in case you lose pressure, and then you want to get whatever is stuck in there, whatever little bit you can get out of their mouth or their lungs right before you turn them over, and everything changes. You also are going to want to stabilize their neck and their tube during turning. That's the only thing the RT is responsible for, is holding their neck, holding the tube, and as they turn their body, you're turning their tube and making sure everything stays connected. And RT is responsible for counting down every patient movement. Because you're managing the most important part of the whole procedure, you are the one who gets to say when you're ready to go. So then we have a checklist right here. And this kind of just goes over the same things that I just talked about, especially for the role of the RT. This checklist right here doesn't include an RT. The nursing technician, as it says, is responsible for a lot of the airway things, but this is just what it would look like. So you can see there's like a pre-maneuver time in and a post-maneuver time out. You're going to want to check where the tube was before and after you turn. You're going to want to ensure that you've checked their skin breakdown and keep that documented after you turn them. You're going to want to make sure that you have a good team. They recommend about 5 people to at least to turn them, more if it's a heavier person or a person with a lot of different things that are going to have to be watched and held on to. So that is just what a normal checklist would look like to keep everyone accountable. And then we have placing the patient in the prone position. So this picture right here is a picture of a rotoprone bed. This can do what you can do manually to an extent. It can rotate the patient up to 62 degrees laterally, and this one is also in Trendelenburg. So it'll rotate them to a prone position for about 16 hours and then back to a supine position for about 8 hours. And it can keep doing that. That way you don't always have to have a team of 5 people to come in and help you. If you are proning manually, like I said, a team of 5 people is recommended, and you want to make sure that you pull the patient as far from the vent as possible so that you can turn them back the opposite way. So if your vent is on one side of the bed, then you want to pull this patient as far this way as you can, as their circuit will allow. That way you can turn them back this way, and everything will stay connected and also not get tangled up. So that's it for that one. And then we look at the effectiveness of prone positioning. How can we assess it? How can we say, is it working? Is it not working? A lot of times they're going to look at your SpO2 pre and post proning. If your SpO2 is sitting around the mid to low 80s and then it bumps up to the 90s, then it's clearly helping out. If their respiratory rate is going down, their work of breathing is better, they don't have as much dyspnea, and there's better chest expansion, those are all indicators that proning is working. And then some special considerations when proning. You want to prevent as much skin breakdown as possible. Obviously, if they're having to be proned for 16 hours a day for 2 or 3 weeks, there is going to be skin breakdown, just like there would if they were laying in the bed immobile supine for 2 to 3 weeks. But a good way to prevent some skin breakdown, especially around their face, is to reposition them frequently, especially turning their head. So if they lay on this side for like 8 hours, turn them this way so that they're laying on this side for 8 hours. That way you're not having constant pressure on one side of their face, the potential for moisture to break the skin down, anything like that. And if possible, you should be using a bed that's designed for proning, like the Rotoprone bed. There's plenty of other options as well. And if you can't use a bed designed for proning, then you want to use things that are going to help relieve the pressure. They make like these little pads that you can put under patients that one side will raise up, one side will lower to put pressure in better spots. And then also one more note, the patient's limbs should be alternated in the swimmer's position, as they call it, which you saw in that picture where one arm is up, one arm is back. You can alternate those as well. So then lastly, I have a little video here. That's Autumn right there, and I am going to be demonstrating how you prone her. So we have the patient sitting up right at first. You put your bed rails down, but we obviously can't prone her with her sitting up like that. So you're going to want to make sure that you put the bed rails up when you leave the patient unattended. And that's what I'm about to do, is put the bed rails up. So then you're going to want to lay the patient flat. And you want to leave the bed rail up on, if you're doing it by yourself, you want to leave the bed rail up on the side that you're not on, just to prevent the patient from rolling out of the bed. And you'll take the sheet off of the side that you're going to roll on, and she had to scoot a little farther over. You want them as far over as you can so that you can turn them the opposite way without them hitting the bed rails. So here we go. We roll, and she did hit the bed rails just a little bit, but luckily she's not actually intubated right now. And then you want to make sure that they aren't caught face down. So you want to make sure that their tube is out, their head is to the side. You see me putting her in the swimmer's position, fixing her bed sheets. And don't forget to put your bed rail back up as well. And that's it for that video. So just a little summary of what we went over here. We talked about the indications, contraindications, the reasons why we would do it, what you want to consider before you do it, and what your role as the RT is. We looked at a checklist. We looked at a rotoprone bed and techniques you can use when proning a patient. Talked about how you can assess the effectiveness, and looked at some ways that you can prevent skin breakdown, and also how they should be positioned while they are proned.